Okay. So before going into the hemoglobinopathies, okay, some words about the structure of the hemoglobin. Okay, hemoglobin is actually composed of heme and globin. Globin is amino acid chain proteins. Okay, and heme is containing iron. Okay, so yesterday when I was talking about just a second, I was discussing about iron metabolism. So there are so many things which are related to it that dietary iron is absorbed in two forms. One is animal source and one is plants like elemental iron. Okay, so the heme iron is the one which is important for the synthesis of hemoglobin. Okay, and there are certain mechanism for absorption of iron and certain mechanism for storage of iron. I'm just trying to, because we don't need too much details. We should have a concept. That's what like absorption is done in duodenum. Okay, and then like in any other cell, it is stored like in the form of ferritin. Okay, so this is one point. And there is another form of iron storage. What is that one, if anyone wants to tell? Which is you can say a problematic form. Yes, Zishan, Usman, Dr. Dora, anyone wants to speak out? That form is hemosiderin. Okay.
Hemoglobin, yes.
Yes, which is, you can say, a slightly inactive sort of form, which is a problematic form, and ferritin is a readily usable form. Okay, so this is one point which you should be knowing. Then another point which should be knowing is that there is a mechanism through there is a thing which is called as hepcidin. Okay, you can see over here. This is hepcidin, and actually hepcidin is the one which is controlling the iron absorption. Okay, and so this is, and actually this hepcidin is working in an uncontrolled way through inflammatory process, and that's a pathology for anemia of chronic disease. Okay, in anemia of chronic disease there is high levels of hepcidin which are stopping iron absorption. Okay, so this is a concept we should be knowing. And another concept which is important for iron, related to iron, is the movement of iron throughout the body. That is through which thing? How iron is transported throughout the body?
Transferrin.
Yes, it is transferrin. Okay, so you should have a concept what is transferrin, what is ferritin. This is transferrin. Okay, ferritin, hemosiderin. Okay, and then hepcidin. Then what is this one? There is one more thing. Transport, absorption of iron, storage of iron, transport of iron, and negative feedback, you can say, or control mechanism of iron, because iron cannot be removed from the body easily. Okay, it cannot be excreted through the kidneys or like that. So this is another concept which they can ask you in the MCQs, is that the stored iron is in ferric form, Fe3 plus. Okay, and absorbed iron is in ferrous form. The thing which is absorbed is in Fe2 plus. Okay, so the whatever iron is stored is in the form of ferric. So ferritin, hemosiderin. Okay, as they have told you that it is common to all body cells. It's there everywhere in the body, and this hemosiderin is, you can say, inactive sort of complex which is formed. Okay, then another thing is that when there is too much, you see, that's what I was telling you. The hepcidin is acute phase protein that is also expressed under condition of infection and systemic inflammation in response to cytokine, principally interleukin. That this host response to infection limits the amount of circulating iron available to any invading pathogen. Through the response, hepcidin is responsible for iron sequestration seen in the anemia of chronic disease. Okay, so hepcidin expression is down-regulated by increased RBC production, erythropoiesis, iron deficiency, and tissue hypoxia. So hepcidin is a control mechanism. Okay, so transfer, I told you through transferrin. Okay, the bound to transferrin, and so there is one hereditary hemochromatosis, and if there is excess load as occur in repeated blood transfusion, which occurs in thalassemia. Okay. So there is the mechanism to tackle this is either through venesection or through chelation therapy. What is the chelation agent for iron overload? I don't recall it. I think it's not written here.
Desferoxamine.
Desferoxamine.
Desferoxamine. And what about copper? There is something for copper as well. Is it the same one?
No, copper has another name.
Ceruloplasmin or something? I don't remember it. Okay. So anyways, so we will just go towards the hemoglobin. So there are alpha chain and beta chain, and according to its alignment, there are three usual forms which are there in normal condition. One is hemoglobin A1, A2, and what is occurring in fetal hemoglobin. Okay, alpha chain and beta
Gamma
chains.
chains.
So another hemoglobins which are different are methemoglobin, and another hemoglobin which is there in carbon monoxide poisoning. We will just try to have a look on this one. This was, I was just opening yesterday. I was showing you that they can, this in this count is important to us. Okay. Of course, in anesthesia exam, they will not be asking about erythropoiesis, but usually what is happening that at the end of the day, the heme iron is transported to the bone marrow, and then the erythropoiesis occurs. Okay, so and then after that RBCs are removed by macrophages. Okay, and spleen. Okay, and then heme component and globin component is occurring. Then heme is again transported by transferrin, and it is again recycled. Okay, when iron is released from its storage site and absorbed from the gut, it combined with transferrin and gets transported to the bone marrow, where it is used for RBC production. Okay. Biliverdin gets converted into bilirubin. Biliverdin so biliverdin gets converted into bilirubin, which enters the circulation and is transported to liver, which is secreted into the bile. Okay. So as we know that oxygen transport mainly occurs with the the main role of hemoglobin is for oxygen transport. Actually, I'm quite distracted when there is sound in the mic. Okay, so mainly it is the oxygen carried by the hemoglobin. So as I told you that A1 has 2 alpha chains and 2 beta chains. Okay, and A2 is 2 alpha chain and 2 gamma chains. Okay, this is MCQ question. This is total cramming, but you should be knowing about it. And the fetal form is 2 alpha and 2 gamma chains. So actually fetal hemoglobin has too much affinity for oxygen. So the shift of the curve to the left. Okay, and it is replaced after in the adult life when the baby is
Yes,
born.
P50 is also shifted. P50 value is also shifted.
P50 if shifted to the left. So it may be around 21 or 19, something like that.
18, yes, 18.
And it is increased. I will just show you. You will be, because you see, thing is that anemia topic finish with 4 or 5 things. But actually, if you want to understand anemia, I will just show you the thing in few minutes. So it is related to the oxygen hemoglobin dissociation curve, which is very important. Okay, so that's why when I started the topic, there is one thing is oxygen, like you can say this was transfer through the lungs to the blood. This is one thing. Okay, exchange, it's not the correct word actually, exchange, oxygen exchange. And then the second is oxygen transport. Okay. And the third thing is oxygen delivery. And the fourth thing is oxygen utilization. Okay. So at the end of the day, if anything is impairing, the result is actually just like anemia. Okay. If the body is not getting the, and that will be resulting in anaerobic metabolism, and that will be resulting in acidosis, things like that. Okay. So we will go in detail about sickle cell and thalassemia, but I will just tell here what happens. That actually in sickle cell anemia, you can say the if it is either it is like homozygous or heterozygous, and then it becomes sickle cell trait or sickle cell disease. Sickle cell disease is a more severe form, and sickle cell trait is with heterozygous. So it is tolerating some of hypoxia. What has happened? Okay. So this is another thing. And then in thalassemia, there is problem with the ELF, where it may be problem with the globin side. Okay. So again, the hemoglobin is abnormal. Okay. So it is not able to, sickle cell disease, it is not able to tolerate the stress. Okay. And similar thing occur in thalassemia. Okay. Anyways, some other points: oxygen binds to ferrous iron in hemoglobin. Okay. By forming a reversible bond. There is no oxidative reactions, and so the iron atom always remains in the ferrous form. In the condition methemoglobinemia, the ferrous ion is oxidized into ferric form. Now you understand what happens in methemoglobinemia. Okay. So now oxygen is not being carried by the hemoglobin. Okay. Each molecule of hemoglobin can bind 4 molecules, and there is maybe they will write here that first is difficult, and after that there is some structural change which increase affinity for the rest of the binding of rest of the oxygen molecules. Okay. There are several factors that influence binding, including local oxygen tension, local tissue environment, temperature, CO2, hydrogen ion 2,3-DPG. We will just go shortly there. Okay. So dissolved form is very less significant. And when we are giving the hyperbaric oxygen therapy, actually we are increasing the PO2, and that has effect on the dissolved oxygen saturation. Okay. Dissolved oxygen concentration. Okay. This chart is written in kPa. So 1 kPa is 7.5 millimeter of mercury. Okay. So this is I think 21. Usman, I think it is like that. 21 P50.
21 P50 value, sir.
Yes, 3.5 they have written, 3.5 kPa. So I think it is around 221, am I right?
I think slightly more than 21.
Yes, it will be around 24 or side. Anyways, because we are not
24.
used to
20.
we are not used to kPa values in our part of
Sir,
world.
we multiplied by 7.5.
7.5. So I think it will just because maybe it is, I'm not able to convert it. I think it is 27. The normal P50 value.
Yes.
P50 is the oxygen saturation at which 50% is
50% of the hemoglobin is saturated with
hemoglobin is
oxygen.
saturated at the partial pressure of oxygen. Okay. So this is the normal oxygen hemoglobin dissociation curve. Okay. This is arterial side as
Yes, the venous point, the arterial point is asked. What is the venous point? What is the arterial point? What is the P50 value? It is changed in pregnancy and in
and if it is
fetus.
shifted to the right, it will be, the
Yes.
curve will be that like more PO2. The concept is that what is right shift or left shift, that more PO2 is required to saturate that much oxygen.
Yes,
That,
Bohr's effect,
that much
Haldane effect. These
hemoglobin.
are all asked.
Okay, when it is more
Double Bohr
towards
effect.
getting more, so you can say that more PO2 is needed to saturate the hemoglobin. That's a simple concept what we target in oxygen hemoglobin dissociation curve. Okay. So that's what I was telling you. When oxygen binds to hemoglobin, the two beta chains move closer together. This is actually details, but simple words remain that first binding is difficult, and after that there is change in hemoglobin structure, that more hemoglobin that you see. When oxygen binds to hemoglobin, the two beta chains move closer together and change the position of heme moieties that assumes a relaxed or R state. When oxygen dissociates from hemoglobin, the reverse happens, and the heme moieties take up a tense or T state. When oxygen binding to hemoglobin, the relaxed state is favored, which has an increased affinity of oxygen, so facilitates the uptake of additional oxygen. This occurs at the site of lungs, where it is taking the oxygen. And when it is reaching the periphery, it is in the other phase, so that oxygen is moving out of the hemoglobin and going to the tissues. Okay. The affinity of the hemoglobin for the fourth oxygen molecule is therefore much greater than that for the first. That's what I was telling. Okay. This is the frequently asked question in MCQs and everything. And actually that is the important thing, that when there is like practically speaking, when we that's what we face in post-operative period. When there is hypothermia, the oxygen hemoglobin dissociation curve is shifted to the left. When actually this is a very, very important factor for a patient with myocardial ischemia, ischemic heart disease, because that oxygen will not be able to utilized, and that can result in a very disastrous situation. Okay. Similar occurs in carboxyhemoglobin, methemoglobin, or even hemoglobin F, fetal hemoglobin. Okay. And because of acidosis, stored blood, why it should be on the left? Because it is acidosis. Usman?
No, sir. The stored blood is more alkalotic than acidosis.
Okay, I think this is because of citrate, am I right?
Because of the no, yes, and because her store blood has got less 2,3 BPG. That's why.
Yes. Decrease in 2,3 DPG, because when the cell lysis occurs, then 2,3
Yes.
DPG are decreased. Okay, so Bohr effect, as I that occurs with the less affinity of hemoglobin to oxygen. Okay, so it is kicking out oxygen, and it is going towards the periphery. So this is rightward shift of oxygen hemoglobin dissociation curve. That's what is shown here. Okay, because in anemia, pregnancy, and altitude, okay, there is the shift of hemoglobin to the right, so that more oxygen is delivered to the tissues, and the requirement as occurs in pregnancy, because it is required more. This is also a concept which they ask in MCQ, double Bohr effect, or they can ask you in the EDA exams, things like that. But you should be knowing it, that on the fetal, this occurs in the placenta level. Okay, so on the fetal side, shift is curved toward the left, and on the maternal
Yes.
side, it is shift towards the right. So this is called as double Bohr effect. So this will facilitate the oxygen coming out of the hemoglobin on the placental side, and on the other side when it is passing, and then there is more affinity. So it is going. So this is a concept actually this helps in facilitating oxygen transfer from the from the mother side to the fetal side. Okay. The increase in PCO2 in the maternal villus assist oxygen unloading. Okay. So it more CO2 is kicking out oxygen out of hemoglobin. The decrease in PCO2 on the fetal side of circulation assists oxygen loading. The Bohr effect facilitates the reciprocal change of oxygen for carbon dioxide. The double Bohr effect means that the oxygen dissociation curve for maternal hemoglobin A and hemoglobin F move apart. Okay, you understand this thing? Okay, so the Haldane effect is the ability of the deoxygenated hemoglobin to carry carbon dioxide. Okay, so one oxygen is coming out, so other friend is coming in. Okay, so
It
conversely,
is more in effects at lungs.
yes, at the level of lungs, because there is more CO2 there to be transferred out. Okay, and O2 is being used already. So deoxygenated
There is increased
hemoglobin.
affinity of oxygen and less affinity of carbon, basically, in
Yes.
a nutshell.
Yes, yes. Okay. So this is another thing. And then myoglobin. Myoglobin with reference to which problem, and practically we are afraid in which problem, which is that problem in which myoglobin becomes important for us.
Rhabdomyolysis.
Rhabdomyolysis. Okay. And there is other, it can lead to hyperkalemia because of cell lysis, and it is related to even in normal trauma. When we are discussing about polytrauma patient, we should be considering, or we should be telling that if there is element of crush injury, this will be
Yes, cola colored urine, typical.
yes, and patient can go into acute renal failure. Okay, so myoglobin also, sorry.
Even seizures can cause.
Yes, seizures. How will be it related to
Status epilepticus, you
Status
can say.
epilepticus.
Yes, okay. So so it has a high affinity for hemoglobin, and so its dissociation curves lies to the left of the oxygen hemoglobin dissociation. That's what is here. Okay. Okay. Actually, the next step of hemoglobin, whenever there is a problem, the exact thing which is occurring is hypoxia. Okay. So the effect of low hemoglobin delivery, no oxygen delivery to the tissues is hypoxia. Okay. So we should be knowing about this concept. That one is hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, and histotoxic hypoxia. Okay. So hypoxic hypoxia is when oxygen is not actually, there is no smuggling of oxygen. So no oxygen is coming. So that will, when there is no oxygen, then it is a real, you can say that hypoxic hypoxia is a real hypoxia. Okay. Then the other, that the oxygen is there, but there is no car, no taxi transport service is not there. There is lockdown. Okay. So there is low hemoglobin. So that is name it as anemic hypoxia. Okay. Because in that there is low hemoglobin level, and because there is more hemoglobin to be transported through the adjacent to hemoglobin, so that is very important for anesthetic. That's why we are always looking at the hemoglobin level. Then third is a stagnant hypoxia, in which there is failure of the pump. The driver is there, sorry, the car is there, but driver is not there. So the pump, that is heart. Okay. So heart is not able to make the circulation in that way, because one thing is oxygen content. The concept to understand that one thing is oxygen content, and the other thing is cardiac output. So in stagnant hypoxia, there is no cardiac output. Oxygen content, we are dealing with the related to hemoglobin, and related to the oxygen smuggling. I'm using simple
Dissolve.
words to make you understand. So one is hemoglobin, that is the car, that is the person who's traveler. Okay. And this is the driver. So if there is no driver, if even a content is there, it's not, cannot be transported. Okay. And histotoxic hypoxia, the traveler is going there, but cells are angry, so they are not using it. So that's what occur in cyanide poisoning. Okay. And that is hypoxia at the tissue level. And in this case, what will be the result on mixed venous oxygen saturation? It will be high. Am I right?
Yes, high venous and high lactate.
And what about sepsis? In sepsis, early
Oh,
phases, or you can say, sorry, not early phases, late phases, actually the same picture can occur, in which actually mixed venous oxygen saturation can high and become very high. Am I right, Usman?
Yes, in the late stage, but not in early stage.
Not in early stage. Okay. So that is the normal oxygen hemoglobin dissociation curve. Okay. So what has happened here? I will just what has happened here? This was 13.3. Okay. So now you see that because I showed it. So now this is the real hypoxia. So there is no oxygen. So the PO, you can see PO2 is reduced. Okay. So venous saturation also decrease. It was around 5.3. It has become 3.5 because there is no oxygen. So more oxygen is being extracted. So venous oxygen even comes more. Okay. What is this? Okay. This is normal. Sorry, this is PO2 is normal, but venous is low because there is less hemoglobin. Okay. This is what is occurring in anemic hypoxia. Global oxygen delivery is reduced due to reduced oxygen content. Okay. Result in increased oxygen extraction and venous desaturation. So whatever hemoglobin is there, it's saturated and it is extracting more. So the PO2 low. Okay.
Hyperbola curve,
Yes.
is this?
Okay. So in stagnant hypoxia, both the values are normal. Okay, but tissue and organs do not receive the oxygenated blood due to perfusion failure. Okay. And this is one, and they are angry. The cells are angry. So they are not using it. Okay, they are not able to utilize it. That's what occur in cyanide poisoning. Okay. PO2 is normal. Cells are unable to utilize oxygen, resulting in high venous oxygen saturations. Cyanide poisoning will also be associated with the left shift of the oxygen hemoglobin dissociation curve. Okay. So that's we discussed before. There are to get the oxygen content. There is one bound to the hemoglobin and one is dissolved. This is Hafner's constant, which is the amount of hemoglobin taken by each gram of hemoglobin. Okay, so that is 1.34 to 1.39 in the acidic this oxygenated and deoxygenated. Okay, so oxygen content we calculate, and then this is the difference in oxygen venous and arterial. That will the oxygen delivery. Okay, multiplied, as I told you, multiplied by cardiac output is the oxygen delivered. Okay. Okay. So this you can be asked in, especially in exams like FRCA, primary FRCA, MCAI exam or EDA exam. This is high yield topic for them. Okay. And as anesthetist, you should have a concept about it. So this is the picture of hypoxic hypoxia, in which hemoglobin is normal and saturation is low. So the result is less oxygen content. Okay. And then in anemic hypoxia, again, say this one hemoglobin is very low. So there is significant effect on oxygen content. So you can just have a look on it. Okay. Actually, this topic of oxygen transport, they can ask you as oxygen cascade. They can ask you as oxygen flux. Okay. So this is another name of is oxygen flux. So that's what happens here, that when we are in, what is the atmospheric pressure? 760 millimeter of mercury. Okay. It is around 101 kPa. Out of that, 21% is oxygen. So that will become the partial pressure of oxygen. Okay. Then when it enters, there is humidification. So that is the effect of humidification. There is vapor pressure that will be minus. Okay. Then there is mixing with dead space. Okay. And it is transported that in the arterial blood side. Arterial side, it is 13.3 kPa or around 98, 99. Okay. Then it is in the and the mitochondrial level, you see 1 to 2 kPa only. Okay. What is the concept? Usman, do you know about posture point? Because I have read quite a while ago. So what is posture point?
Which point, sir?
Posture point, what is this point? I
Posture
think this
point?
is the
No, sir. No,
critical.
no.
Yes, it is the critical point at which the anaerobic respiration starts.
Yes, this is the yes.
Anaerobic threshold.
No, not anaerobic threshold. Actually, if the PO2, you see that this is the level of in the level of mitochondria. Even if this amount of oxygen partial pressure is there, so aerobic metabolism will continue. Okay, but
Okay,
if it is
okay.
decreased even less than that, so that is the point for anaerobic metabolism. Okay. That's why oxygen, 100% oxygen is, that's why actually not required in all the cases. Okay. And that's why it is resulting in the oxygen free radicals, which are actually histotoxic. Okay. Cytotoxic oxygen free radicals. What do you mean by this AA gradient? When there is alveolar arterial gradient, if there is someone is taking bribe, so the alveolar pressure is not as compared to the arterial side. So this is related to the diffusion impairment. Like if there is water over there, membrane. If water is there, is edema. If there are too much garden over there, it's not allowing to have the gaseous exchange. This is fibrosis. Okay.
Yes,
And
fibrosis.
if there is severe hypotension, there will be again VQ mismatch and shunting when lungs are not ventilated. So
Yes.
the deoxygenated blood is directly going to the other side. Okay. So that can occur in right to left cardiac shunt as well. And if it is intrapulmonary shunt because of atelectasis. That's why this is just a practical point that before extubation, it is always advisable to give up CPAP. Okay. While the endotracheal tube is inside. I don't know if it is written in any book or not, but practically I am giving you a hint that of course, if you have a patient with the COPD, so you should not try this this adventure. But in any other patient, if you just close the APL valve and just let the airway pressure get a little bit higher, so that this will be giving you a very good margin when you extubate the patient. Because if you are giving this, actually this is a painful stimulus as well. So if you just try this, and you will see that even the patient becomes they will be a little bit irritable for. But actually this is a practical tip. Please don't quote it somewhere. But practically, I'm telling you that this is a very good mimic to do before extubation. Okay. Even if the patient is awake, just try to do it for a few seconds, because this will give you a very good result in the after extubation. Okay. The same thing you can do after extubation as well, but that will create more of gastro aerophagia. Okay. Because when you increase the pressure while the tube is out, okay, now that pressure is going towards the stomach as well. But if you are giving it only through the endotracheal tube, so very less amount is transferred to the stomach side, the haram area. Okay. So that's a concept I just wanted to give you. Okay. So low, like that, this is just the summary of what we have discussed. Low inspired oxygen if the oxygen you are giving is less, or patient is unable to have the ventilation, or there is anemia, there is no hemoglobin to take the oxygen, and the tissues are angry, and there is VQ mismatch, if there is problem with the impairment with the diffusion, and if there is shunting, there is lockdown, the oxygen, the blood is not able to uh, transport it to have a contact with the lungs. Okay, so that is what we discussed. Okay. Okay. To increase the oxygen content, that's what we practically do. Whatever we have discussed, the practical we do like that we increase the hemoglobin. We just try to have higher oxygen saturation by supplemental oxygen. Okay. And the other component is through hyperbaric. If you want to increase the partial pressure of the oxygen through the dissolved oxygen. Okay. And then the more important thing is to have the good cardiac output, good coronary perfusion. That will, because if heart is itself ischemic, heart will not be able to have a good contractility. Okay, because if to maintain the stroke volume, you should have an optimal preload, you should have an optimal afterload, otherwise the whole of the system will collapse. So for maintaining the oxygen delivery to the heart, you have to bribe the heart with the reasonable parameters, the rate, because heart rate is the most important factor. This is another practical tip I will tell you, that if you want to see that your anesthesia is good, just try to check the heart rate response when you are intubating a patient. If a heart rate response is around, you can, liberally I am saying 20%, you say that your anesthesia technique is good. Okay, but if it is, ideally it should be around 10%. So 10 to 20%, okay, acceptable. If your heart rate is jumping more than 20%, it means you are not giving a good anesthesia, so you should do something, because in normal patient nothing will happen, but in a diseased heart this can create big problem. Okay, so because there is a myth that in regurgitation lesion you want higher heart rates. It doesn't mean that you want to have 100 heart rate. Okay, it means that you should not have bradycardia. Okay, so that's a concept we should be knowing even when you are correlating it with the valvular heart disease or anything like that. Okay, so maintain perfusion pressures to ensure organ oxygen delivery. Okay, so that is the afterload, as I told you. And then you will be targeting according to the situation. You will use either fluids, you will use either inotropes, or if anything, you need to increase the afterload, or you have to maintain the afterload. Okay, so that's what I wanted to tell you. Okay, any questions up till now? I have just given you a feeler, because actually, basic sciences is really difficult to explain. And if you have read it many years ago, it becomes even more difficult. So I have just give you a hint, and then you can read it from the sources I will share to you. Okay. This is a very confusing thing. 2,3-DPG, what is it? Is a highly anionic organic phosphate, which promotes the release of oxygen from hemoglobin. It is produced by a side shunt reaction of glycolysis and is present in large quantities in erythrocytes. Okay. 1,2,3-DPG molecule binds between the beta globin chains of deoxyhemoglobin, altering the protein structure and so reducing oxygen affinity. So this is that 2,3-DPG, what is it is doing? 2,3-DPG is trying to unload the oxygen, so it is creating some change in the structure of the beta globin chain of deoxyhemoglobin. Okay, so the production of 2,3-DPG is increased in anemia. As a result, the relative tissue hypoxia is partially corrected by the increased P50, promoting more oxygen release. Usually, how much oxygen is delivered? We just discussed that out of 20, we are delivering 5. So usually it is 25%, which has the highest oxygen extraction. Highest oxygen extraction is usually by heart and brain. Okay. So that's the concept of 2,3-DPG. You read number of times. So this is what is happening with the 2,3-DPG. Okay. What else? So because we have discussed these things, tomorrow we will discuss, inshallah, sickle cell disease and thalassemia. Okay. Thanks, Shamail. I think if you all of you read this topic of